Hello, this is Steve Bonsib, coming to you again from Arkana Laboratories in Little Rock, Arkansas. Uh, this is the third part of a six-part series on developmental abnormalities and cystic kidney diseases, and this is part two of congenital anomalies of the kidney and urinary tract. Today I'm going to discuss renal hypoplasia, which is a fairly complicated topic with a number of different iterations or versions of renal hypoplasia. Renal hypoplasia is one of the most misused terms in urologic diseases, and this is because of a reliance on imaging studies in which historically all small kidneys were regarded as hypoplastic. As you can see here, chronic atrophic pyelo, end-stage obstructive uropathy, small dysplastic or aplastic kidneys, chronic ischemia, and truly hyperplastic kidneys are all wrapped under the general term renal hypoplasia if reliance on imaging is employed. An example of this is the largest series of renal hypoplasia, or so-called hypoplasia, was reported by Ekstrom way back in 1955. Of 179 cases, 46 were studied histologically, and only 4 of 46 were small and histologically normal. That's important because normally developed nephrons must be present in order to diagnose renal hypoplasia. Rubinstein in 1961 established a pathologic mandate when he defined hypoplasia as congenitally decreased amount of histologically normal tissue. There are a radiographic and a pathologic definitions of hypoplasia. The European Network on Rare Kidney Disease employs a radiographic definition of a kidney being less than 2 standard deviation score for length with normal corticomedullary differentiation. It's important for normal corticomedullary differentiation to be present to distinguish it from renal dysplasia. In the Colvin and Chang textbook, Diagnostic Pathology, Kidney Diseases, 2 forms of hypoplasia are discussed, simple hypoplasia and oligomeganephronia. Simple hypoplasia is defined as architecturally normal kidneys with reduced number of nephrons and lobes and a kidney weight less than 50%. Conversely, oligomeganephronia has the same definition as simple hypoplasia, but there is in addition marked compensatory nephron hypertrophy. Historically, 3 types of hypoplasia have been identified. In addition to simple hypoplasia or oligomeganephronia, segmental hypoplasia, also known as Ascup-Mark kidney, was the first form of hypoplasia identified. Some do not regard this as a form of hypoplasia because it is closely related to reflux, which is likely occurring in utero, but despite that, it does have hypoplastic features, as I will illustrate in a moment. There are 2 additional developmental abnormalities that fall into this general category of hypoplasia. One is oligonephronia, not to be confused with oligomeganephronia, also known as low nephron number or low nephron endowment. And it, I believe, is the link between normal kidneys and hypoplastic kidneys. I will discuss this last. In addition, I'd like to first discuss reduced nephron generations, which is sometimes referred to as cortical hypoplasia, and this is determined by a process called radioglomerular counting, and I will discuss that first. So reduced nephron generations or cortical hypoplasia is basically premature cessation of glomerulogenesis. Since the kidney grows centrifugally, in other words, the deeper layers of the cortex, as I discussed in the embryology portion of this series, the deeper portions of deeper glomeruli are the older ones, with additional newer ones laid down row after row. In a normal kidney, if you orient the section along a medullary ray, the row-like orientation of glomeruli is easily discerned. In the normal kidney, 10 to 12 rows are normal, although admittedly some extrapolation is necessary. Hinchcliffe proposed grading severity of reduced nephron generations, as shown, normal being greater than 10 and severe less than 4. And this is a diagram from his book which shows how you count the nephron generations, and not all glomeruli are going to be in the plane of section you're viewing, so some extrapolation is required. This is an example of how nephron generations form rows. Here in this adult kidney on the left, we have one row of glomeruli here, a second row here, and a third row up here. So we can see three nephron generations. This is only part of the cortex. A number of other generations were present. In addition, here on the right, I have a newborn kidney in which the row-like orientation is even more readily seen. The medullary rays are right here on the side, and we have 1, 2, 3, 4, and 5 nephron rows, or a radioglomerular count of 5 if that was the entire cortex. Now, radioglomerular counting has been used for many years to establish gestational age in a fetus, provided the kidney structure is normal. And this is just a table illustrating how at 27 weeks, in the normal situation, you have 6 to 8 nephron generations, whereas out here at 32 weeks, you've got 11 to 13 and so forth. Now, there are many causes of reduced radio count or cortical hypoplasia. This includes the 3 forms of hypoplasia I'm going to discuss next, as well as a number of ureteral abnormalities shown here. This kind of makes intuitive sense, since the ampullary bud, which forms the ureter, induces nephrogenesis. And if the ureter itself cannot develop normally, you might expect that its ability to induce nephrogenesis might be impaired as well. In addition, there are a number of maternal causes I have listed here too: prematurity and small for gestational age. The effect of prematurity is shown in this graph from this Japanese article published in 1993, where here at the bottom we have gestational age in weeks, and here on the left column we have the radioglomerular count. And as you can see, there's a fairly linear pattern of increase in nephrogenesis with increasing gestational age. Approximately 60% of the nephrons are formed out here in the 3rd trimester, and since the ampullary bud undergoes dichotomous branching with glomerulogenesis induced, you can envision that a fetus with a radioglomerular count of 5 versus one with 6 is going to have 1/2 as many nephrons, whereas someone with a radioglomerular count of 7 will roughly have 4 times as many as someone with a radioglomerular count of 5. Here's just an example of reduced nephron generations or cortical hypoplasia. These sections are from 2 infants. They were both born with bilateral small kidneys. And if we look here on the left, we have the medullary rays visible, and we can count 1, 2, 3, 4, 5, maybe 6 nephron generations. Whereas in the image on the right, we can see again the medullary rays, but this kidney has a radioglomerular count of only 3, so a marked degree of hypoplasia. Okay, now I'm going to discuss the 3 types of hypoplasia. I'm going to begin with segmental hypoplasia, also known as Ask-Upmark kidney. This was first described by Dr. Ask-Upmark way back in 1929, so it was the first form of hypoplasia identified. This typically presents in neonates or children, but occasionally detection is delayed until adulthood. Patients typically have severe hypertension, and if the hypoplastic focus is single, surgery can cure the hypertension provided the contralateral kidney is normal. Ask-upmark kidney is associated with vesicoureteral reflux in 90% of cases, thus the suggestion by some that it's closely related to reflux nephropathy. However, as I'll show in a moment, there are hypoplastic features that I think justify including it in our hypoplasia lexicon. The kidneys, ask-upmark kidneys, are very distinctive grossly. They have a deep cortical groove, which is shown here in this diagram. Both the photomicrograph and the diagram are from Dr. Ask-upmark's article in 1929. It's in German, so I couldn't read the article, but I did extract these images from that publication. So these cortical grooves are deep, and there's approximation of the collecting system with the renal capsule with just a small amount of tissue, which is devoid of nephrons, normal or sclerotic. There are no blastemal-derived structures at all. Here's some gross photographs of ask-upmark kidney. Here on the left, we can again see the very deep cortical groove here, which is shown in the bivalve kidney right here, where the collecting system and the renal capsule are closely approximated. But there are other hypoplastic lobes as well, scattered in the polar regions. The gross photograph on the right shows multiple hypoplastic foci, and these hypoplastic foci are very distinctive microscopically. And here shows, I've shown a couple of cases of hypoplastic foci in ask-upmark kidney. First of all, they're sharply delineated from the adjacent normal-appearing nephrons, as we can see right here. And in this image right here, again, the hypoplastic focus is bracketed by morphologically normal-appearing glomeruli. The hypoplastic focus itself has large dilated vessels, and if you look at high power, there's no evidence of glomerular sclerosis or tubular atrophy. No hint of blastemal differentiation is present. In some of the hypoplastic foci, you will have some rudimentary renal medullary tissue formed. The medullary tissue consists solely of collecting ducts and peritubular capillaries. No loops of Henle are present because no glomeruli were present. If you look at the histologically normal-appearing nephrons in the adjacent cortex, you will see cortical hypoplasia or reduced nephron generation. And here's an example of a 2-year-old and a 19-year-old kidney with ask-upmark segmental hypoplasia, in which adjacent renal lobes showed, in this case, only 2 nephron generations, and in the case on the right, only 3 nephron generations. So there was a marked reduction in radioglomerular count. So in addition to the hypoplastic focus, there is cortical hypoplasia in some of the adjacent lobes. For those that would like to wrap segmental hypoplasia into reflex nephropathy as we understand it, this is an example of a typical reflex nephropathy gross, where we have the polar scars, the typical location of scars in reflex nephropathy. And if you look at the scars, they are truly scars, although they are sharply delineated from the adjacent normal lobes. Within the scarred area, we have sclerotic glomeruli and a thyroidization pattern of tubular atrophy. So this demonstrates that normal nephronic differentiation had occurred, but then secondarily underwent sclerosis, which is much different than the segmental hypoplastic foci in ask-upmark kidneys. Moving on to simple hypoplasia. Simple hypoplasia is usually unilateral, but maybe bilateral. This example here on the right, the gross photograph from Dr. Bernstein's review article published in 1968, shows a markedly hypoplastic kidney on the right side of this image, with a hypertrophied kidney on the left side of the image. The definition of simple hypoplasia, as I indicated previously, is 5 or fewer lobes, less than 50% normal weight, which this certainly qualifies. This process is asymptomatic when unilateral, provided the contralateral is kidney is normal. However, the contralateral kidney may itself be affected by another K-cut abnormality, in which case renal function will not be normal. Here are a couple of examples of simple hypoplasia. On the left, I have an example of bilateral simple hypoplasia. Notice how the kidneys are odd-shaped. They're very rounded or globular in their profile. And if we attempt to count renal lobes, certainly the one on the left probably has 5 or fewer lobes. The one on the right has a marked reduction in renal lobes, but technically is a little bit larger than the hypoplastic, simple hypoplastic definition of 5 or fewer lobes. It probably has 7 or 8 lobes, so slightly larger. The middle image shows a unilateral simple hypoplasia. This was from a 50-year-old female. The kidney weighed 50 grams and had just 4 or 5 lobes. And again, in both of these situations, the cortical tissue showed completely normal nephron development. Here's an example of unilateral simple hypoplasia in an adult. Now, technically, this is a little larger than the simple hypoplasia definition. It was 8 centimeters in size and contained about 7 lobes. Again, histologically normal. Renal function was normal because the contralateral kidney was of normal size. And this is just simply to illustrate the fact that the definition of hypoplasia, simple hypoplasia, is somewhat arbitrary, with a threshold of less than 50% normal weight and 5 or fewer lobes. And obviously, kidneys are going to show a spectrum of hypoplasia ranging from a normal adult, a normal size kidney, to a technically hypoplastic kidney. So this kind of falls in the middle ground. Okay, oligomeganephronia was first described in the American literature in 1968. Several publications in the French literature had preceded that. Oligomeganephronia is invariably a bilateral disease and has the similar definition of 5 or fewer lobes and less than 50% normal weight. As the name indicates, the nephrons are markedly enlarged. And since it's a bilateral process with marked reduction in total nephron number, these patients present with CKD and inevitably develop end-stage renal disease. And this table here on the right shows a number of patients with oligomeganephronia and the age of onset of end-stage renal disease. Here are some gross photographs of oligomeganephronic hypoplasia showing marked reduction in renal size. Sort of difficult to count lobes, but clearly both of these kidneys probably have 3 or fewer lobes. The image on the right shows a kidney with 2 lobes and a kidney with 1 lobe. So these patients are obviously going to present with CKD and end-stage renal disease at an early age because of bilateral involvement. There have been a couple of studies in which nephron microdissections have been performed, which emphasize the marked nephronomegaly seen in oligomeganephronia. The image on the left in the center is a normal nephron, and it's bracketed by 2 oligomeganephronic nephrons. And we can see the tubule diameter is much larger and the tubular length is much longer. Similarly, here on the right side, we have a normal control here, second and fourth, whereas the first and third microdissections are oligomeganephronic nephrons. And as we can see, the glomeruli is a much larger diameter, the tubular diameter is larger, and the length of the tubule is longer. The increased tubular length means in a renal biopsy core, there's going to be widely spaced glomeruli or reduced glomerular density. Here's an example of glomeruli in oligomeganephronia with compared to an age-matched control here on the right. As you can see in the left and middle images, there is marked enlargement of the glomeruli, and if we were to try to count capillary loops, which would be very, very difficult, there's a marked increase in capillary loops as well as glomerular size. So if we compare simple hypoplasia and oligomeganephronic hypoplasia, I would propose that they're essentially the same entity, but they differ in circumstance, namely laterality and age of detection. And by that I mean, if you look at simple hypoplasia, it's usually unilateral, whereas oligomeganephronia is bilateral. They have the same definition in terms of size and number of, or weight and number of lobes. They both very often have cortical hypoplasia or reduced radial glomerular count. Since simple hypoplasia is unilateral, the contralateral kidney is normal or hypertrophied, thus those patients do not present with CKD or end-stage renal disease. However, oligomeganephronia is a bilateral disease, thus those patients do present with CKD and end-stage renal disease. This is an example of what would be called simple hypoplasia. It's in a 2-year-old with bilateral small kidneys. The outer medulla is down here. If we perform a radial glomerular count, it's about 3, so marked reduction in nephron generations. Now, if this infant had survived longer, these kidneys would have undergone compensatory nephromegaly and would at that point be called oligomeganephronia. So that's why I think simple hypoplasia and oligomeganephronia differ simply in the fact that one is bilateral, the other is usually unilateral, and they may vary in the onset of encounter. The final topic I'd like to discuss is oligonephronia, which is reduced nephron number or nephron endowment. However, it is not quantified otherwise. And I believe it's the bridge between normal kidneys and hypoplasia. If you tuned into the first segment of this series where I discussed renal embryology, I pointed out that the number of nephrons in otherwise normal kidneys can vary up to 13-fold, and there are many factors that affect nephron endowment. And here's a table from that first talk, again, where on the right column here, I have the mean glomerular number, which is usually listed in the literature as an average of 900,000 to 1 million nephrons per kidney. But here in the middle, it demonstrates the range we can see amongst various ethnicities in adults and children. And again, a broad range of nephron numbers, 13-fold. In this case here, 210,000, 2.7 million, and so forth. There are many causes of oligonephronia or reduced nephron number. Many of them are listed in this table. There's the demographic. In some studies, females appear to have 9 to 12% fewer nephrons than males. Taller individuals have an increase of 28,000 glomeruli per centimeter increase. There is an age-related decline in nephron numbers of almost 3,700 per kidney per year. There are very important maternal and intrauterine causes listed here, in which we have decreased glomerular numbers and decreased radial glomerular counts. Ureteral abnormalities, as I previously discussed, and a number of mutations, and this is just for many other mutations have been shown to have varying degrees of reduced glomerular number, and these 10% up to 20% as listed here. Now, why is oligonephronia an important concept? Well, in 1988, Brenner proposed that low nephron number increased the risk of chronic kidney disease and hypertension in adults due to hyperfiltration of the remaining glomeruli. That said, the relationship between nephron number in hypertension was actually first observed by Heyman way back in 1929. If we return to this table that I previously showed, up here at the top, this is the Heyman study in which he showed if you have fewer than 700,000 nephrons, 100% of his patients had hypertension. Conversely, if you had greater than 1 million nephrons per kidney, only 15% of patients had hypertension. This study right here was by Keller, published in 2002, and it's one of several other studies that has showed a similar relationship. In the case of Keller's study, hypertensive patients had a mean glomerular number of 702,000, whereas normotensive patients had a nephron number of 1.429 million. So a marked difference in nephron number. Now, in addition, we can see some changes in patients with low nephron number. One of those that's most obvious is large nephrons, which means both large glomeruli as well as enlargement of the tubular portion. And if you look at these tables here, several studies have shown that with decreasing weight, the glomerular volume increases, and with decreasing glomerular number, the glomerular volume increases. So large glomeruli then can be a surrogate marker for low nephron number when detected in non-scarred kidneys. And I'll show you an example of that. I think oligonephronia can be inferred occasionally on a biopsy, and this is an example. If we look at these two cores here, this is from a 23-year-old female who radiographically had small kidneys and proteinuria, and the biopsy shows low glomerular density. There's one glomerulus here, a second one here, and a third one here we're just catching the edge of. But in a normal kidney, we would expect to have maybe 6, 7, or even 8 glomeruli within cores of this length. If we look at the glomeruli themselves, they are markedly enlarged. And so the wide separation between glomeruli is due to enlargement of the tubular portion of the nephron. So if we combine low glomerular density, large glomeruli in small kidneys without scarring, I think we can quite logically infer that a marked reduction in nephron number is present. Here's another example which maybe is a little more challenging to recognize. This is a biopsy from a 16-year-old with 10 and 11 centimeter kidney and creatinine elevation to 1.7. Now, 10 and 11 centimeters may be approximately normal size for a 16-year-old male. However, the creatinine of 1.7 is due to acute tubular injury, which results in interstitial edema and artifactual enlargement of the kidney size. So if this individual had normal renal function and no interstitial edema, in all likelihood, the glomerular or the kidney size would be less, who knows, maybe 8 or 9 centimeters. So if we look at the glomeruli, notice there's marked glomerular enlargement with numerous capillary loops. So if we combine large glomeruli with small or even normal sized kidney, we can infer low nephron number is present. So this is my last slide, which summarizes my thoughts about renal hypoplasia in its various versions that I've just discussed. When an entity is first discussed, the most severe forms of it are recognized, and in this case that would be simple hypoplasia and oligomeganephronia. They occupy the lowest end of the nephron number spectrum, and they're responsible for neonatal and infantile to teenage onset of hypertension, CKD, and end-stage renal disease when bilateral. And I believe oligonephronia and then is the bridge between normal nephron number and hypoplasia. Oligonephronia carries a substantial risk of adult onset hypertension and CKD, but may present in an adolescent or young adult as CKD or proteinuria, depending on the degree of oligonephronia present. And it also represents a situation where the individual has a low renal reserve with any source of renal injury. Conversely, supranormal nephron number, in other words, nephron numbers that might be 1.5 or 2 million nephrons per kidney, these patients have a very low risk of adult onset CKD and hypertension, and they could represent a large renal reserve that may afford a more favorable outcome when kidneys are affected by any renal injury. As far as I know, this postulate has not been tested, but I think you can envision, for instance, if we look at diabetics, only 30 to 40% of diabetics develop progressive diabetic nephropathy. The remainder do not. Possibly those that do not are individuals that have a very high nephron number compared to those that are affected by diabetic nephropathy. Well, that concludes this third segment of the 6-part series. The next 2 segments will cover the ciliopathies and autosomal dominant tubulointerstitial disease. I hope you'll tune in for these additional talks. Thank you.